Good evening. Welcome to the next episode of Beyond 2020, a project of the Nebraska Optometric Association. This episode we have Dr. Cheryl Chapman from Gretna, Nebraska, who also happens to be a board member for one of the leading myopia management groups here in the country. So the first episode we had Dr. Chris Wolf on, and I always say for the size of our state, we have some pretty influential optometrists that we get to practice with and we get to learn from, and you certainly are in that group with what you're doing here with Myopia Control. So thank you for joining us.
Thanks, Drew. I'm really excited to be here.
Excellent, excellent. Well, the first thing, the Myopia Control is something new for not only doctors in a lot of respects, but also for patients to even think of or even consider. And so I guess when you start the conversation, why would we even talk about controlling nearsightedness? I mean, if a parent's nearsighted and they've made it that far in life, why should they worry about it?
Well, I think that the conversation around nearsightedness has really evolved and changed. I think a lot of doctors are starting to switch their thinking. Nearsightedness is not just a refractive error. It's not just needing glasses. We're starting to think of it more as a disease of the eye. And the reason we're thinking that is because there are so many other complications that happen much more commonly with people who are nearsighted. As you know, when someone is nearsighted, the eyeball grows longer and longer and longer. As that prescription is getting stronger, the eyeball is stretching out. And that's where the concern really comes in. So as the eyeball becomes more stretched, we see a higher incidence of problems such as glaucoma, such as retinal detachments, and other problems with retinal stretching, like something called myopic maculopathy. And the problem with that is you'll see increased loss of vision. The longer the eyeball is, the higher the risk is. And so doctors are becoming more and more aware of a lot of these complications, and it's becoming more pressing because we are seeing that a greater number of the population is becoming nearsighted. And often patients will ask me, well, why is this happening? And the answer is, it's how we use our eyes. So if you think about like when we were kids, or even when our parents were kids, how much near work did they really have to do? We see now that students are required to do a lot more in terms of studying, but it's not just studying, it's also when we are in our leisure time. We're all on devices. We don't spend nearly as much time outdoors. And so that, I would say, is why we're starting to pay a lot more attention to it. But also, we now have more knowledge on things that we can do to help stop that progression. And so that's what really gets me excited. Knowing that I can reduce someone's risk of vision loss throughout the course of their lifetime just with some really simple steps, that gets me really excited and passionate about it.
Yeah. I mean, I'm not that old, but I can remember most of my learning was still on a chalkboard. Maybe we got some expo markers going by the end of that, but you read some books during the day, but you still did a lot at distance. And so I think one of the concepts of like myopia, causes of myopia, and why even outdoor play is so important is that idea of just the image in our retina that's in the periphery. And so something we don't think about, certainly a patient doesn't think about, but understanding that what the peripheral part of our eye sees does cause us to get more nearsighted, and being outside where essentially at a super far distance, we're kind of in 2D instead of 3D, and that affects how fast or slow our eyes do change or grow. So when we're talking about this increase in nearsightedness, not to put you on the spot, but any numbers in terms of what do we have right now? And let's start with the United States as far as the incidence of nearsightedness. How many people roughly are nearsighted in our population?
So it's roughly doubled within one generation. It used to be around 25%. Now we're nearing 42% of the population is becoming nearsighted. And we're projected worldwide, they expect about 50% of the world's population to be nearsighted by the year 2050. And that's a lot. Not only that, but the amount of nearsighted people who have really, really high amounts of nearsightedness has increased as well.
So let's talk about the high nearsightedness, because I think a lot of patients, they'll, while a -2 prescription is certainly impactful to that person individually, Would you consider that an average nearsighted prescription, a below average nearsighted prescription, roughly, in terms of the population?
So I would say that that is probably low to moderate. The World Health Organization has defined -5 and above as high nearsightedness.
Yeah. So I don't think a lot of people realize they think of their vision as being bad when they're -2, and it certainly impacts their lives. But we see patients, as you know, that are beyond -5, -10. I happen to have a -19 patient out there.
Wow.
So it can, as the people will say when I mention that, they're like, well, it can get worse. So I think those health issues that you mentioned, those are the big ones, though, right? Those are the ones that, besides the fact that when you're highly nearsighted and you take your glasses off, you can't see anything. Those are the issues that impact even when you put your glasses on.
Right.
You're not going to be able to see, right? So let's talk about retinal detachments. How much more likely are you to have a retinal detachment if you are above that -5, -6 range?
So that's interesting that you ask. A lot of people talk about it in terms of diopters, -2 diopters, -5 diopters. Realistically, the real risk factor is length of the eye. And so if you look at every diopter matters, every millimeter of length of the eye matters. So the average human eye is about 24 millimeters long. And there was a study, a retrospective study that looked at roughly about 20,000 patients and their risk of vision loss after age 75. And in this particular study, vision loss was defined as vision that is 20/40 or worse, even with glasses. And an eye that is more than 26 millimeters long, so that's 2 millimeters longer than average, an eye that is over 26 millimeters long, that person has a 1 in 4 chance of having vision loss 20/40 or worse with correction by the time they're age 75.
Which, I don't know if you remember this or not, but is 20/40, is that the cutoff for daytime driving?
That is the cutoff for an unrestricted driver's license.
Yeah. So we were talking that even at 75, you might be healthy and active, but you may have implications in terms of your driving ability.
That's correct. And so, every patient's different. Sometimes a person with a -2 prescription can have a 26 millimeter eye. Sometimes a person with a -5 prescription will have a 26 millimeter eye. And the reason that varies is because your prescription isn't based only on eye length. It's also based on the lens inside of your eye, that's the structure that develops cataracts, and it's also based on the curvature of the front of your eye. And so I think it's really important when we're looking at nearsightedness that we're not just talking about power changes, we're also talking about what is the length of the eye, and we now have more instrumentation available that a lot of eye doctors are getting where they can readily measure that. But to kind of circle back and answer your original question, what is that risk of that retinal detachment? We know that people, like if you're just like around a -1, you have a risk of retinal detachment maybe 5 or 6 times more than the average person. But by the time you get to these prescriptions that are high nearsightedness, like a -5 or a -6, some studies say that your risk of retinal detachment is maybe 80 times higher than normal. And it just depends on what studies you're looking at. But we know for a fact that the risk is much, much, much higher if you have that longer eye.
So one of the things, people have heard about macular degeneration before, but myopic maculopathy is obviously not something that's out in the common vernacular. Would you describe that as something similar, as far as from a patient standpoint, something similar to macular degeneration for a patient?
Yes, very much so. So myopic maculopathy basically means the very center part of the retina becomes so stretched out that it develops almost like cracks in it. I always think of it like, when a pregnant lady gets stretch marks on her belly, that's what happens right in the center of the retina, basically, and the photoreceptors can't work right then. So people with macular degeneration who have like age-related macular degeneration, they lose their central vision, but they can still see out here in the periphery. That very same symptom or sign happens when patients with high nearsightedness, when they develop that myopic maculopathy. Same thing happens. They lose their central vision, but they still have, this peripheral vision, hopefully, unless they've developed glaucoma or retinal detachment or other problems like that. So.
Well, let's go back to kind of risk factors of this progression. So from a patient side of things, kind of thinking about their their family's lifestyle or kind of history, what are kind of is there a list of 5 things to kind of think about or watch out for or kind of address within your own family? Or?
Sure, that's a really good question. So when you're seeing patients and you're kind of trying to figure out what their risk is, there's certain things that you kind of have top of mind. So number 1, ethnicity. We know that certain ethnicities have a much higher incidence of developing nearsightedness. People who have Asian ancestry are at the highest risk. And then we look at parental myopia. So if you have a parent who is nearsighted or 2 parents who are nearsighted, then you also are more likely to become nearsighted. And then we also look at age of onset. So if a child is 9 years of age or younger when they first transition into nearsightedness, we know that they are at much higher risk for progression and fast progression of nearsightedness. And then we look at their rate of change. So if a child is changing, patients always talk about steps. How many steps did I change? If they're changing by 4 steps or 1 full diopter within a 12-month period, we consider that very fast progression. So that puts them at higher risk for continued fast progression. And then we look at environment. So if a child is spending 2 hours or more of time with near work per day, outside of school, we spend a lot of that time at school. But if they're getting more than 2 hours of near work per day, that's increased risk.
So would you, on that one, really quick question, would you say that's outside, you said that's outside of school, 2 extra hours, or are you taking school into consideration?
I think you really have to consider school time there. And then if they are spending less than 2 hours outside per day, then that's also a risk factor. So lots of things play into it.
So from a parent standpoint of kind of strategies, let's say before we get into the actual things we can do to try to slow this down, from a habits side of things, it sounds like we should be recommending just more outdoor playtime, less time away from near tasks. Even I've had the conversation with parents, my child is a great reader, loves to read books, and she or he reads all the time, every night, and kind of have to have that talk about, hey, reading is great and books are great, but you do need to be aware of this, especially if we're seeing change when they're coming in, and kind of it feels weird to try to tell them not to read.
Right.
But it's an interesting conversation, right?
I never want to tell a child to not read, because I think that's a key to a great education and great learning. So I would rather manage their myopia and encourage them to continue to read. Yeah. However, I would say let's cut out some of the other near work. Maybe they don't need to play Minecraft as often. Things like that. A note about outdoor time and other what we would call visual hygiene. So we know from studies that increased time spent outdoors can help reduce onset of nearsightedness. However, we don't necessarily see that as like a valid treatment. It's not like if you all of a sudden are sending your child outside more, they're not necessarily going to become nearsighted. But we also know that once they are already nearsighted, it's not nearly as impactful. So that's something to keep in mind. But then I also like to talk to parents about positioning. So if a child is very, very close to their stuff, that's no good. So I always say, think about this 90-degree angle. And also, you don't want a child to be, some kids, they like to tilt their head with their work. So one eye is really, really close to the page and one eye is further away from the page. Sometimes that can cause uneven prescription between the 2 eyes. So I just always, remind the parent to make sure that their kid has a really proper working distance, because that is impactful sometimes.
Those are great tips. All right, let's get to the good stuff then.
Okay.
So there's kind of 3 different routes sort of that we can go here. So let's kind of break those down. So let's start with option number 1. What would you say is your best option to try to slow this down to start with?
Well, every patient is different, and you have to kind of look at each patient individually and say, okay, what is their current prescription? What's the curvature of their cornea? How old are they? What is their maturity level? What is their hygiene level? How sensitive are they with their eyes? And I take all of that and I consider all of those factors. And so I wouldn't necessarily say that I have an absolute favorite, but I can go through the 3 different methods and talk about maybe what is better about some and what is better about others. So probably my personal favorite, if everything else was equal, would be orthokeratology. Orthokeratology is something that a lot of patients are very unfamiliar with, and it sounds really weird the first time they hear about it. But basically what we do is we design a retainer mold that sits on the eye while the patient is sleeping at night, so they sleep with it on, and they take it off in the morning. When you wear orthokeratology retainer molds, they gently reshape the cornea while you sleep, and that changes the way the light rays enter the eye, and that can help stop the increased length growth of the eye. And it also makes it so that the patient can see clearly and comfortably without any glasses or daytime contact lenses. So from a quality of life perspective, it's really great because if you've got a child who's very active in sports, if they're a swimmer, to not have to worry about having contacts or glasses on during the day is really pretty nice. And some of the newer customizable retainer molds are so customizable that we can really customize the amount of myopia or the amount of nearsightedness control that we're getting with them. So that's really pretty neat. It also can more easily manage things like astigmatism that some of the other options aren't as good at. But not every child is a good candidate for orthokeratology. Certain prescriptions can sometimes be too high for ortho-K. Or if the child is very irresponsible, not a good hand washer, dirty fingernails, maybe you're worried about them putting that in their eye if they don't have good hygiene habits. Or maybe you've got a child who has really poor sleeping habits. So if they are maybe a teenager and they're up at night gaming and things like that and they're not getting consistent sleep, having something that works while you sleep may not be the right answer for that person. And then we've got kids who are just too nervous to have something touch their eyes. But I fit Ortho-K routinely in kids as young as 6 and 7 years old, and they do remarkably well with it. One of the other methods that we use are soft daytime contact lenses, and it's not just any standard soft lens. It is a specific type of multifocal, and not even all multifocal contacts work this way. There's just a few specific ones on the market. But that is for a child who doesn't have a lot of astigmatism and maybe can't tolerate the nighttime ones, or they're a little skittish because you've always heard never sleep with a contact in your eye at night. So sometimes people just choose that daytime modality for that reason. Or if we've got a higher prescription that the Ortho-K overnight lenses can't manage, so that can be really good. And then the third method of myopia management is low concentration atropine eye drops. So atropine eye drops, when they're used full strength, are strong dilation drops. They make the pupil really big, they can make stuff close up blurry, they can make you more light sensitive, just like when you have your eyes dilated. But when we use atropine to treat myopia or nearsightedness, we do it in very, very low concentrations. So most patients don't have those side effects, or if they do, they're very minimal and can be managed pretty easily with just maybe like a bifocal pair of glasses, or some sunglasses or transition glasses. The atropine eye drops are, when we're trying to do them in low concentrations like this, they are a more specialized drop. They need to be compounded, which means you can't just pick them up at any pharmacy. So eye doctors who are using that are using special compounding pharmacies to have those drops made. And those are really becoming more and more available and pretty accessible. And sometimes you've got a patient who needs more than one method. So I have some patients who do both orthokeratology and atropine eye drops to get the best myopia management. No method of myopia management is guaranteed to be 100% effective. The studies show us that we can slow progression on average by about 50%. And so we're rarely stopping it. We're slowing it down. But I would say the newer stuff that's coming out is actually, we're far exceeding that 50% control in most cases now. Those studies that quote that 50% control are based on older technologies sometimes. So we're having really, really good luck with it. And sometimes we'll transition patients. So I've had patients where we've started with the low concentration atropine eye drops because they're very sensitive to things touching their eyes and they're nervous. And then, we're on that for 6 months or a year, and the patient's getting more mature, and now it's really easy to touch their eye. They're really comfortable with that. And then we transition them into, one of either the soft daytime contacts or the overnight orthokeratology molds.
I think one of the things recently, just from helping patients kind of parents wrap their minds around this is, like you said at the beginning, sometimes you hear about this and maybe you're skeptical, don't exactly understand what we're talking about or what we're offering as a solution. And so when you first talked about the Ortho-K and as a retainer, I mean, it's kind of like wearing a retainer for your teeth, right? And getting your teeth to realign or stay in the right position, and that's what we're trying to do with the eye and keep it from growing. And then the other side of that is going to the soft lenses, and again, doesn't mean that they're more effective than any of the other options, but that is where we've had the first FDA approved option come out. And so there's multiple soft lenses that work really well in that world, but it is nice to see that the FDA and some of the other people that are involved in making decisions and policies and things recognize it.
Getting FDA approval on that contact lens for helping reduce nearsightedness progression was huge because it was the first step towards the FDA actually viewing myopia as a disease rather than just a state of vision.
What we have to accept.
What's that?
What we have to accept.
What we have to accept,
you're going to
yes.
be nearsighted no matter what.
Yeah. And so I think that was huge because that will help us move other things into a market that's more accessible. So for example, the low concentration atropine drops, they can only be made in compounding pharmacies. Well, now that we've had the FDA actually recognize myopia as a problem or nearsightedness as a problem, it's going to be easier to get these low concentration atropine drops where they're just made by companies and then stocked at regular pharmacies. So it's not happening yet, but it's on the horizon.
We're getting closer. Excellent. Well, we've got options and we've got opportunity, right?
Yes.
Well, Dr. Chapman, it's been great having you with us today. I think one of the things patients need to realize is that they can ask these questions to their optometrist. Optometrists have friends and colleagues, if they don't do it, that can answer and help get them guided in the right spot. And if we can slow down those changes in little ones, it really can affect us long term. Not only for that individual kiddo, but long term as a society. If we can slow down myopia, it will reduce cost of even glasses lenses if someone ends up being a -2 instead of a -10 or something like that. And the one thing I kind of bring up with patients too when they ask why would you think about this is that there are always new surgeries and procedures that are coming around, but a lot of times those surgeries and procedures have certain ranges that are applicable, and if you certainly get above a -4 or -5, a lot of times, at least initially, you can't do those. So who knows what's out there in the future for that, and if we can keep you at a low rate, you've got options, right?
Right. I mean, ask any LASIK surgeon, they would way rather do LASIK on a -3 than a -9 any day of the week. So.
Well, thank you for being here. We really appreciate it.
Thank you, Drew.
All right, and Dr. Chapman, if a parent wanted to kind of research on their own to come up with questions to ask their optometrist, where might they go to look up information about all of this?
Well, one of my favorite resources is an organization that I'm on the board of directors for, and that is the American Academy of Orthokeratology and Myopia Control. And they go by AAOMC. And if you go to their website, you'll see that they have a practitioner site, but they also have a patient site. And I think it's got some really great resources that patients can go to learn more. And they can even search doctors. They have like a doctor locator. You can search doctors in your area that do manage myopia.
Excellent. Thank you.
Thank you.
We also would like to give a thanks to the Nebraska Optometric Association and the Executive Director, Dave McBride, Beyond2020 producer, Christian Anderson with Right Eye Digital, Parsons Public Relations. We do want to encourage everybody to look for the latest episode of Beyond 2020 at bettereyecarenebraska.com, on the NOA YouTube channel, and all your favorite podcast platforms, and also follow us on Facebook. If you have questions, please contact us at Nebraska Optometric Association. Until next time, thanks for watching and listening.